Well, here we are again. You've come to Menopause University, and I've come to teach you everything you need to know in order to really understand all the things that affect your menopause. This channel is really and truly a school. I tell you the truth, the whole truth, and nothing but the truth about everything. And that includes schooling you on all the diseases that you need to avoid. So we are in the midst of a big unit on epithelial ovarian cancer. It's one of the most important diseases to avoid. And that's because we have no way of diagnosing it early enough to actually treat it and cure it. And while there are some specific hereditary risk factors that increase your likelihood of getting it, they account for only 20% of all epithelial ovarian cancers. The other 80% occur randomly in women who do not consider themselves at high risk for it. Here's the big chart of risk factors that you've seen over a dozen times now. Focus on the orange section. It's the reproductive and hormonal category of risk factors. That's what we'll be addressing today. But in the context of preventing epithelial ovarian cancer rather than increasing your risk for it. Now, I hope you have my book. It is a great complement to these videos. And while everything is in my book, the depth and detail of the information is always greater in these videos. I can just do more in a video than I can in a book. But in the book, all of chapter 32 is on epithelial ovarian cancer, and you'll find an abbreviated version of today's lesson there. So this tutorial focuses on your reproductive and hormonal options for preventing epithelial ovarian cancer. Now, you know how much I abhor the general tendency for people to merge topics that are actually separate. And although these two items are merged into one category of risk factors on the chart, your reproductive options for preventing epithelial ovarian cancer are actually separate from your hormonal options for preventing epithelial ovarian cancer. So I'll separate reproductive options from hormonal options in this video tutorial. Let's begin with your reproductive options for preventing epithelial ovarian cancer. Depending on your age, you may or may not still have the opportunity to exercise these options. If you are pre-menopausal, you can use this information to plan your reproductive choices. If you are postmenopausal, it's too late to change anything about your reproductive choices. And if you're perimenopausal, you could fall into either scenario. In the breast cancer unit and this unit, you have seen that your risks for both breast cancer and epithelial ovarian cancer are greatly affected by how many menstrual cycles you have in your lifetime. The more you have, the higher your risk. The fewer cycles you have, the lower your risk. We call the number of menstrual cycles you've had in your lifetime your menstrual life. It's a calculation as follows. All you do is start with your age at post-menopause. From your post-menopausal age, subtract your age when you had your first period. Then multiply that by 13. You multiply by 13 because you actually have 13 menstrual cycles each calendar year, not 12. Then you subtract from that the number of months you were pregnant, using 10 months for each term pregnancy. Subtract 1 month for each month of prematurity if you had a near-term pregnancy. And then you subtract from that the total number of months you breastfed. The answer is your menstrual life. Once you have the number representing your menstrual life, there's a scale for what constitutes low risk, high risk, and very high risk. These parameters are defined for your breast cancer risk only. They are not specified for epithelial ovarian cancer. But they still give you an idea of the typical range simply because the risk factors for the two cancers are almost identical. If your answer for menstrual life is fewer than 350 menstrual cycles in your lifetime, you have a low risk for both breast cancer and epithelial ovarian cancer based on your menstrual life. If your answer is between 350 and 450 menstrual cycles in your lifetime, you have a high risk for both breast cancer and epithelial ovarian cancer based on your menstrual life. And if your answer is more than 450 menstrual cycles in your lifetime, you have a very high risk for both breast cancer and epithelial ovarian cancer based on your menstrual life. The bottom line is that the more menstrual cycles you have in your lifetime, the higher your risk for epithelial ovarian cancer, regardless of the reasons for your high number of menstrual cycles. Here's the chart we made in previous videos to demonstrate this. You see that younger age at menopause, fewer or no pregnancies, fewer or no months of breastfeeding, infertility, infertility drugs, and older age at postmenopause all serve to increase the number of menstrual cycles you have. The reason this is the case is because your ovaries were designed by Mother Nature to progress through a cycle that includes pregnancy. So, your ovaries are supposed to progress through pre-puberty, in which they are dormant, to puberty, in which they grow, to forming an ovulatory cyst in response to estrogen stimulation in the first half of your menstrual cycle, to forming a corpus luteum cyst that produces progesterone in the second half of your cycle, to growth of the corpus luteum cyst to support a pregnancy, to even more growth of the corpus luteum cyst to the point of being able to function as a cradle for the pregnancy until the placenta develops enough to take over. And then your ovarian cycle ceases completely until you finish breastfeeding. In other words, your ovaries are supposed to have a passive phase in which they get a great big vacation from egg production. If you have multiple pregnancies, your ovaries cycle through these prolonged, completed cycles again and again and again. So with pregnancy, 3 critical things occur. 1, the corpus luteum cyst gets larger. 2, the corpus luteum cyst lingers for months. And 3, the entire ovarian cycle stops for the duration of the pregnancy. But by avoiding pregnancy, your ovaries are denied the opportunity to go through the entire cycle. Instead, by not getting pregnant, we abort the cycle, and then we start it all over again. So in that scenario, this is what happens. Of course, you still start out with pre-puberty, in which your ovaries are basically dormant, and then you have puberty to where they become larger and more mature. And then you form the ovulatory cyst in the first half of your cycle. And then you form the corpus luteum cyst in the second half of your cycle. But that's it. After that, your ovaries return to their plump, pre-pregnant state, and the cycle begins all over again. And you just have these 3 phases over and over and over again. The longer you evade pregnancy, the more aborted cycles you have. So you end up with one aborted cycle after another, after another, after another. And your ovaries never get the hiatus that you get from pregnancy. They are on the job, running the factory 24/7, month after month, year after year. Either way, from puberty to postmenopause, your ovaries start this cycle over and over and over again. In both cases, what differs is whether the cycle is extended and completed by cycling through pregnancy or aborted and restarted by evading pregnancy. If you have many pregnancies, your ovaries have fewer cycles, but they are more completed cycles. If you have few or no pregnancies, your ovaries have many more cycles, but they are incomplete cycles. Either way, you finally get to post-menopause. That's here and here. This is by definition when your ovaries go out of business. They stop producing eggs and hormones. The entire factory closes down. So your ovaries die, but you go on living. So it all boils down to the number of ovarian cycles you have in your lifetime. This means that women who are like the old woman who lived in a shoe and have so many children they don't know what to do have decreased their risk of epithelial ovarian cancer by reproducing so much. And the rest of us don't have that advantage. So, one means of decreasing the number of menstrual cycles you have in your lifetime is to have a whole lot of pregnancies. So, as I said earlier, if you're already post-menopausal, there isn't much you can do about your reproductive life to prevent epithelial ovarian cancer at this point. But if you're watching my videos as a pre-menopausal woman, you can use this information as you please. I always say that my big dream is for all women to get this education on menopause in their 20s. Can you imagine a world in which all women learned all this stuff in their 20s? Can you imagine your own life if you had gotten this education in your 20s? If you have a granddaughter, a daughter-in-law, a daughter, or a niece, do this. Tell her you want her to spend just 45 minutes of quality time with you each week. Get together and put your cell phones in another room. That's mandatory. Then start with video number 1 and watch all my videos in order. Just one each week with your loved one. And by the time your loved one needs this education, she will have it. And I assure you that she will tell the whole world that you were the person who made all the difference for her. Now, when I think about the fact that more pregnancies mean lower risk for epithelial ovarian cancer, I can't help but think about Jeff Davis Hospital. That was one of the 6 hospitals of my medical school and residency education and program in Houston, Texas. Jeff Davis was quite literally a baby factory. The entire hospital was for nothing but obstetrics. It catered to the indigent population of women with no insurance. And the indigent population tends to have more children than the non-indigent population. At Jeff Davis, we delivered 50 babies every 8 hours. Every single year, Jeff Davis Hospital either exceeded or matched the number of deliveries at LA County Hospital. They both had the reputation of being the biggest baby factories in the entire United States. And we, Baylor College of Medicine residents, ran the whole Jeff Davis facility all by ourselves. We had attendings on call should we need them, but who had time to call on an attending? And face it, calling an attending was a sign of weakness. Medicine is a bit like the military. You never want to look weak. So Jeff Davis was fast and furious, just the way I like it. But because it was a population of poor pregnant women, non-English speaking pregnant women, and teenage pregnant women who had not had prenatal care in the nice, orderly way they deserve, Jeff Davis was a zoo. We encountered everything you can imagine, everywhere you can imagine. Because the vast majority of these women didn't drive, they often came to the hospital very late or too late in the course of their labor. So we delivered babies in the parking lot, in elevators, you name it. And because of the high volume of patients and low volume of doctors, there was no way to provide continuity of care in which a single doctor follows a single patient through her labor, delivery, and postpartum care. No, the place was much too busy for that. So instead, we ran it like a factory. Each resident was assigned to a room. There were separate rooms for triage, workups, labor, delivery, C-sections, tubal ligations, recovery, and intensive care. And once a resident was in a particular room, he or she stayed in that room and just did the same thing for every woman who passed through the room. The whole place functioned as an assembly line. My favorite place was always the operating room, and I got the operating room a lot. That's because I was a very fast and efficient surgeon. I mean, you can't have the operating surgeon backing up the whole assembly line. So I'd go to the operating room and do C-section after C-section after C-section every 15 minutes, skin to skin. And we worked 36-hour shifts. So there were times when I did this for hours on end. And I loved every minute of it. I'm warped that way. Now, Jeff Davis was great for obstetrics training, but most women don't want to deliver their babies in a baby factory, nor do they want to be baby factories. So the vast majority of women do not have enough pregnancies to decrease the number of menstrual cycles they have and decrease their risk of epithelial ovarian cancer. So what else can decrease your risk by decreasing the number of menstrual cycles you've had? Breastfeeding can. Thus far, I've discussed breastfeeding and pregnancy together, but clearly they are not the same. Not every woman who has children chooses to breastfeed them, nor do pregnancy and breastfeeding have the same exact degree of effect on decreasing your risk of epithelial ovarian cancer. Pregnancy has the greater effect of the two by far. So if you had pregnancies but did not breastfeed, you still decreased your risk of epithelial ovarian cancer a bunch. But how much does breastfeeding contribute all by itself? Let's address breastfeeding in isolation. Obviously, it's difficult to compare breastfeeding without including pregnancy. I mean, one could do a study on wet nurses, But know what? Nobody has done that. So we don't have statistics on how much a wet nurse decreases her risk of epithelial ovarian cancer by breastfeeding only without carrying the pregnancy. The best we can do is compare women who were pregnant and breastfed against women who were pregnant and did not breastfeed. And such studies reveal that women who breastfed had a 24% lower risk of epithelial ovarian cancer than those who did not. The other thing that affects how much breastfeeding decreases your risk is the length of time you breastfed. In general, the longer you breastfed, the lower your risk. If you breastfed for fewer than 3 months per child, you decreased your risk by 18%. If you breastfed for more than 12 months per child, you decreased your risk by 34%, almost double. The problem with these statistics is the per child designation. I mean, obviously, if you breastfed 12 children, that statistic is much higher than if you breastfed only one child. And if you breastfed your one child until he was 7 years old, it's going to count for a lot more decreased risk than if you breastfed him for just a few months. So you can see that the degree to which breastfeeding decreases your risk varies widely. In any case, breastfeeding can significantly impact the degree of risk reduction depending on how long you breastfed. It all boils down to how much you decreased your menstrual life with breastfeeding. But you know, many women avoid being baby factories and breastfeeding by taking birth control pills. These things, I got a bunch of them. So let's talk about the effect of birth control pills on your risk of epithelial ovarian cancer. That's the third factor in this reproductive and hormonal category. I guess you could say that this is the point at which we segue from having lots of pregnancies to having no pregnancies or very few pregnancies. But before we dive into this, let's consider a quiz question. That way it'll help you switch gears and also give you a frame of reference as we move forward. Which of the following is true regarding the effect of oral birth control pills containing both estrogen and progestin on your risk of epithelial ovarian cancer? A, they increase your risk significantly. B, they increase your risk by 10% for every 5 to 7 years of use. C, they increase your risk from 1.4% to 3.3%. D, the longer you take them, the more you increase your risk. E, the higher risk lasts for 35 years after discontinuing birth control pills. F, they decrease your risk significantly. G, they decrease your risk by 10% for every 5 to 7 years of use. H, they decrease your risk from 1.4% to 0.3%. I, the longer you take them, the more you decrease your risk. J, the lower risk lasts for 35 years after discontinuing birth control pills. K, A, B, C, D, and E above. L, F, G, H, I, and J above. What's your verdict on birth control pills? Are they guilty or innocent? I love testing you on things you assume you know. Sometimes you're right, and sometimes you're wrong. Well, without further ado, I will show you the quiz question again with the answer in bold. This means that F they decrease your risk significantly. G, they decrease your risk by 10% for every 5 to 7 years of use. H, they decrease your risk from 1.4% to 0.3%. I, the longer you take them, the more you decrease your risk. And J, the lower risk lasts for 35 years after discontinuing birth control pills. Are you shocked? Well, I'm shocked by the fact that most women have the facts completely upside down. And I'm also shocked at the reasons why they have them completely upside down. You see, I've discovered that doctors commonly offer or encourage women to take birth control pills, but women typically refuse them. And the reasons they refuse them are bizarre. They refuse them because their ignorant girlfriends tell them that birth control pills are dangerous. It turns out that women sabotage one another more than anything else sabotages them. Almost every woman I encounter who ever took birth control pills containing both estrogen and progestin tells me that she stopped them because her girlfriend told her they were dangerous. When I hear this, I calmly ask, where did your girlfriend go to medical school? Sometimes it's mothers who sabotage their daughters in the same way. I'm also shocked by the number of women who refused to take an oral birth control pill prescribed by their doctor, even when prescribed for something other than just birth control. And what shocks me even more than anything is that the very same women who refused to take an oral birth control pill prescribed by their doctor did so because they believed their ignorant girlfriend or non-medical mother over their board-certified doctor. Now, I know that most doctors don't have the time to educate you like I do. The vast majority of women who get a prescription for birth control pills do not learn about all these long-term benefits. But even though menopause is a neglected topic in medicine, birth control is not. So most doctors know the facts about birth control. In my consultations, women are always completely surprised that they knew nothing about the benefits of oral birth control pills. All they've heard about is the risks from their girlfriends and mothers, no less. I am saying birth control pills because that is the only form of combined estrogen and progestin contraception that has been the subject of research studies. But the truth is that any form of birth control that contains both estrogen and progestin qualifies. So this includes birth control pills, birth control patches, and birth control vaginal rings. The big difference is that there are dozens of pills and very, very few patches and vaginal rings. So now that you just learned how pregnancy and breastfeeding decrease your risk of epithelial ovarian cancer by enabling your ovaries to carry out their complete cycle, you are probably scratching your head in trying to figure out how estrogen plus progestin birth control can decrease your risk also. If you are, bravo! I am so proud of you. That kind of questioning means that you are really utilizing this education to connect dots. I always say the truth makes sense. And when you get a complete education, you are able to connect dots to make sense of everything. So let's explore how combined estrogen plus progestin birth control can decrease your risk of epithelial ovarian cancer. In order to make sense of this, you have to understand how estrogen plus progestin birth control prevents pregnancy. I've heard some women say that birth control pills put you in a state of constant pregnancy. And while technically that is not true, physiologically it is true. Estrogen plus progestin birth control works by obliterating your ovarian cycles altogether. They just erase the whole thing. So this is what happens in your ovaries when you have one pregnancy after another. And this is what happens when you have one period after another. The big difference is in the part of the cycle that follows ovulation on either one of them. Ovulation is where everything happens. Well, with pregnancy, you ovulate. But then the consequences of pregnancy take over here, and ultimately they inhibit you from ovulating again for a very long time. But with periods, you ovulate too. But then you abort what would happen as a consequence of pregnancy, and instead you start the whole cycle all over again. Well, with estrogen plus progestin birth control, you basically just inhibit all of it. In other words, you inhibit ovulation. The big underlying key to preventing epithelial ovarian cancer is inhibition of ovulation. And it makes no difference whether you take your birth control in a cyclic or continuous regimen. Either way, you inhibit ovulation. The so-called periods you have on birth control are not really periods. They are merely a consequence of withdrawing the progestin, which causes the lining in your uterus to shed. So it goes from this to this. But because there hasn't been an opportunity for the lining to build up as that much in the first place, your periods on estrogen plus progestin birth control are typically very scanty. But the big key is that there's no egg involved at all. The changes that occur in the lining of your uterus have nothing to do with ovulation. So the underlying reason that estrogen plus progestin birth control prevents epithelial ovarian cancer is that it completely inhibits ovulation. As such, it prevents it to an even greater extent than pregnancy and breastfeeding. The only means of prevention that decreases your risk of epithelial ovarian cancer more than estrogen plus progestin birth control is bilateral salpingo-oophorectomy, or BSO, which I discussed in the last two videos. Bilateral salpingo-oophorectomy decreases your risk of epithelial ovarian cancer by 90%. Birth control containing both estrogen and progestin decreases it by 10% for every 5 to 7 years of use. So if you take estrogen plus progestin birth control pills from age 15 to 55, which is 40 years, you decrease your risk by 40 to 56%. Ultimately, they decrease your risk from 1.4% to 0.3%. And the longer you take them, the more you decrease your risk. That decreased risk lasts for 35 years after stopping them. And despite the fact that this particular unit is only on epithelial ovarian cancer, that is not the only cancer risk you decrease with estrogen plus progestin birth control. You decrease your risk for endometrial uterine cancer and breast cancer also. So you decrease your risk for this and this. So the third means of decreasing your menstrual life is by using estrogen plus progestin birth control for long, long periods of time. I just wish women learned these facts early enough to incorporate them into their reproductive plans if they so desire. Now, there's one more thing to consider with regard to your hormonal risks for epithelial ovarian cancer. Take a look at our chart of risk factors again. Notice the last item in the orange reproductive and hormonal category. It's HRT in the burnt orange color, and it bears a question mark. Be aware that it's a huge question mark. The truth is that this particular one is an unknown, and only a few studies have suggested that HRT might be a risk factor for epithelial ovarian cancer. But to assess the likelihood of that, let's consider a few things. First, consider the age at which you take HRT. You take it when you're post-menopausal, typically starting around the age of 51 or so. In video number 426, you learned that the vast majority of non-hereditary epithelial ovarian cancers develop after menopause. In general, the incidence increases with age, with a sharp increase in the incidence that begins in your mid-40s. Half of all epithelial ovarian cancers occur in women over the age of 63, with 63 being the median age of epithelial ovarian cancer. The incidence of epithelial ovarian cancer in women under the age of 63 is 7.5 cases per 100,000 women. The incidence of epithelial ovarian cancer in women over the age of 63 is more than 42 cases per 100,000 women. So in our previous video, I showed you this graph reflecting the incidence of epithelial ovarian cancer by age. By and large, this is a disease of older women. The age group with the highest incidence of epithelial ovarian cancer is between ages 55 and 70. Oh my, that's the same age group most likely to use HRT. So this overlap of the natural highest incidence of epithelial ovarian cancer with age at which women take HRT makes HRT questionable at best in terms of being a risk factor for it. Second, consider what you just learned about the effect of estrogen plus progestin birth control on your risk of epithelial ovarian cancer. It decreases it a bunch, but the dosages of estrogen and progestin in birth control are much higher than the dosages in HRT. For example, the dosages of estrogen in birth control range between 10 micrograms and 35 micrograms. But the dosages of estrogen in HRT range between 2.5 micrograms and 10 micrograms. It's like the difference between a great big glass of hormones with birth control versus just drops of hormones with HRT. Why would the higher dosage birth control decrease your risk so much, and the lower dosage HRT increase it? How can this decrease your risk and this increase your risk? Does that make sense to you? Progestin dosages vary according to the estrogen dosages, but progestin is not pertinent to your risk of epithelial ovarian cancer. Neither estrogen or progesterone alone is the culprit. cycles are. So this comparison of birth control to HRT makes HRT questionable at best in terms of being a risk factor for epithelial ovarian cancer. Third, consider how many risk factors you have at the time in your life when you take birth control versus the time in your life when you take HRT. This essentially combines the two things we've considered thus far. When you start taking birth control as a young, fertile woman, you don't have many risk factors for epithelial ovarian cancer. It's a disease of older women. But when you start taking HRT as an old or postmenopausal woman, you have a lot of risk factors. HRT did not appear on the list as a possible risk factor until after the WHI terrorized women into thinking that their own body's hormones were poison. That's when researchers started designing studies to keep the terrorism alive. Always pay attention to the effect of fear. Anytime you hear something that doesn't sound logical, but you refrain from questioning it, you are experiencing the power of fear. Do not let fear outmaneuver your brain. This is why I work so hard to teach you logic. Everything should make sense. And the truth makes sense whether you like it or not. And you can always use the information you learn here any way you please. So if we ranked the reproductive and hormonal options in order of risk reduction for epithelial ovarian cancer, we'd get this. Number 1 would be estrogen plus progestin birth control. Number 2 would be pregnancy. And number 3 would be breastfeeding. But they all depend on degree. So that does it for the reproductive and hormonal options for preventing epithelial ovarian cancer. Here's your summary for today. The reproductive and hormonal options for preventing epithelial ovarian cancer include any reproductive history that decreases or omits your ovarian cycles, including older age at menarche, many pregnancies, long duration of breastfeeding, or early age at post-menopause, and estrogen plus progestin birth control. The more pregnancies you have and the longer you breastfeed, the more you lower your risk. Estrogen plus progestin birth control decreases your risk by 10% for every 5 to 7 years of use. Decreases your risk from 1.4% to 0.3%. Decreases your risk more the longer you use it. And that lower risk lasts for 35 years after discontinuing it. All of these means of preventing epithelial ovarian cancer do so by inhibiting ovulation. HRT is a questionable but unlikely risk factor for epithelial ovarian cancer. Alrighty, we are moving right along with your management options for preventing epithelial ovarian cancer. And next week we'll address your lifestyle options. Before you leave here today, be sure you're a subscriber to my channel and my newsletter. And before you come back next week, be sure to schedule a consultation with me at menopausetailor.me. And before you assume that I have absolutely no life outside of delivering this education, find me on Facebook, Instagram, Twitter, and TikTok. My life probably isn't as exciting as yours, but I do have a life. Bye!